So today we would learn about an important syndrome which is usually asked in the AIMS exam, or it can be also asked in your senior residency exam, which is superior oblique sheath syndrome, which is also called Brown syndrome. So what it is basically malfunction of your superior oblique. As you all know, superior oblique is basically an intortor, secondary it is a depressor, and tertiary it is an abductor. So I make a diagram like this. Okay, so it is basically an intortor, secondarily it is a depressor, and tertiary it is an abductor. Okay, so what happens in superior oblique sheath syndrome? There is a difficulty in moving the eye up more in the adduction phase. Okay, and there is a eye pointing in divergence when the patient sees up, and there is a compensatory chin elevation. The most important point here is difficulty in moving the eye up more in the adduction. Now, why this happens? Because of the shortening of your superior oblique tendon. So you can just imagine that it behaves like the superior oblique is preventing the inferior oblique to act. Okay, so there's a shortening of superior oblique. So with what superior oblique does is, it can be basically told that there is a superior oblique. You can say it is not an overaction, but it is a superior oblique which is now a stiff. There is stiffness of the tendon there. Okay, so let's say this is your superior oblique. Okay, it is making the eye stiff, and it is not basically making the eye to move up by the inferior oblique. Now there is a what is the action of inferior oblique? It is an elevator. Remember, the inferior oblique is a better elevator on adduction as compared to your abduction. Okay, it is a better elevator on adduction. Whenever we abduct the eye, the inferior oblique becomes better extorter. Okay, so here there is a decrease in the elevation more in the adduction as compared to the abduction in superior oblique sheath syndrome, which can be a congenital or which can be acquired in the cases just as a blowout fracture. Okay.